Hello and welcome to EJC's Resource Centre on renal cell cancer. In recent years, improved understanding of the molecular background of the disease has led to a number of new agents, which together have substantially improved the outlook for patients. I met Manuela Schmidinger from Vienna, the editor of the Resource Centre, and asked her what the major advances have been.
So there have been a lot of new drugs in kidney cancer. I have to say that we used to treat kidney cancer with immunotherapy based on immunological considerations because this tumor was resistant to chemotherapy and radiotherapy. And then based on a better understanding of the molecular background of this disease, we discovered that in fact inhibiting angiogenesis is the best way to treat this tumor. So there have been 6 new agents now approved for metastatic renal cell cancer, and this has led to a paradigm shift in the treatment of renal cell cancer.
So, the 6 new drugs. First up is the multikinase inhibitor sunitinib. In first-line treatment, it increased response rate and led to a huge improvement in progression-free survival from 5 months with interferon to 11 months with sunitinib. Similar results have been obtained with bevacizumab, the monoclonal antibody targeting the vascular endothelial growth factor in combination with interferon. 2 large trials have found a statistically significant benefit in objective remission and progression-free survival compared to interferon alone. More recently, another multikinase inhibitor, pazopanib, was compared with placebo in cytokine-refractory patients and in treatment-naive patients. It showed significant benefit in response rate and progression-free survival. These 3 agents are typical first-line treatments for patients with a favourable or intermediate risk profile. For patients with a poor risk profile, a randomised phase 3 trial found that treatment with the intravenous mTOR inhibitor temsirolimus gave a significant benefit in overall survival compared with interferon, and is considered the standard treatment for this group. In second-line treatment, after cytokine failure, which is rarely seen now, sorafenib is approved, and data on pazopanib is encouraging. After failure of tyrosine kinase inhibitor, the only agent approved so far is the oral mTOR inhibitor everolimus, which has shown significant benefits over placebo. But there are other agents in the pipeline. These developments are obviously good news for patients, but have they made the clinician's job more complicated?
I think it has become complicated in some way because we suddenly have so many options, while 5 years ago we had only one option and this didn't work very well. So now we have to choose among agents or strategies that all have some activity, some good activity. So the first thing to make a treatment choice is always based on the risk profile, because we distinguish this risk profile between, or we distinguish the treatment strategy for patients with favorable or intermediate risk versus those with poor risk features. And for selecting these patients, we are using the so-called MSKCC criteria, which were first described by Bob Motzer from the Memorial Sloan Kettering Cancer Center. And actually, it goes back to the cytokine era that he identified these risk factors as being relevant for patients with metastatic renal cell cancer, but they have been confirmed today in the era of targeted agents. So the first way to choose a treatment is saying in which risk group is my patient. And then I have to define my treatment goal. If remission is an important treatment goal to me, then I'm tempted to use a drug which provides high remission rates, such as sunitinib. If I say I'd rather choose an agent that is very well tolerated, then I probably may choose pazopanib, which is another oral tyrosine kinase inhibitor with less affinity to the so-called off targets, and therefore has less side effects in some areas such as hand-foot syndrome or stomatitis or fatigue. So it's a matter of defining the risk status of the patient, assessing the patient's comorbidities, and the primary treatment goal, remission versus safety.
Are there treatment algorithms to help physicians make decisions for their patients?
There are several consensus, the EAU, the ESCO, the ESMO consensus, but they are more or less saying the same message, which is for patients with favorable or intermediate risk profile, we have in first line 3 options. This is sunitinib or pazopanib or bevacizumab plus interferon. In poor risk patient in first line, temsirolimus is the standard of care. In second line after cytokine failure, it is sorafenib or pazopanib. This is based on phase 3 data. Sunitinib is an option, but there we have only phase 2 data. And in second line after failure of tyrosine kinase inhibitor, currently everolimus is the standard of care. This is what is said in all 3 algorithms.
So you're very much looking at sequential treatment?
Yes, because sequencing is a way to prolong treatment duration in a patient. And the interesting thing, also we don't have currently phase 3 data on that, but the interesting thing is that it appears that resistance to first-line agents such as sunitinib is temporary. So after using another second-line agent with a different mode of action, it appears that we could even go back to sunitinib in third line and prolonging the patient's treatment duration and in fact patient's life just by using agents again that we have already used in earlier treatment lines.
That sounds like a wonderful thing.
It is, absolutely, because it really has completely changed the fate of our patients.
What needs to happen in future in order to fill the existing gaps?
Our primary goal is always prolonging or increasing the number of long-term survivors. And long-term survival is a matter of overcoming resistance to those agents. And this could be enabled either by novel agents that are under development or already being tested in phase 1 or 2 trials, even more potent agents, or defining or identifying the appropriate sequence. What is the best way to sequence agents? Should we start with the weakest and go to the strongest at the end, or vice versa? This is completely unknown so far. Combination is an interesting way how to maybe increase responses. However, so far trials on combination have proved really challenging due to side effects. And another issue that is important for long-term survival is, of course, the treatment individualization. So we have to, for the future, a goal is to identify the very best treatment for the individual patient, the very best agent for an individual patient. And this could probably be done by genetical investigations.
What place do you see the resource centre having in helping physicians?
I think this resource center will be an excellent tool for making treatment decisions because it contains the most important publications, the relevant clinical trials that have been published in the field of kidney cancer. The resource center will offer very well selected trials that may be of interest to understand the entire picture of this field of kidney cancer, and to guide a physician through the randomized trials, through the pivotal trials, also to see a little bit the background, how did these trials change the treatment paradigm. So I think it will be an excellent way to get a quick access to the most important messages that have been delivered in the last 5 years regarding kidney cancer.